in helping us with this QI initiative. We met every 8 weeks, really Zoom, because that's the easiest way for people to get together. And then we were just brainstorming, how can we make this better for our patients? How can we get them a follow-up within the 28 days? We use the A3 format for problem solving. So we just figured out what our problem was, we broke it down, and then we set a target. And then we're just figuring out like where are our problems, what are we going to do to fix this? So there's a lot of words here, but that is what is going on here. Sorry. So our process map, this is also just shows like what we want ideally and what was happening. So the biggest breakdown is that nobody had the duty put on them of actually scheduling the follow-up visit. So like that's where it was getting lost, and we were figuring out whose responsibility is it to schedule this visit. Like sometimes it was a fellow, sometimes it was the attending, sometimes it was the nurses, the educators. And what was like our ideal way of fixing this problem. So what we figured out is that on Thursdays, we added 2 outpatient clinic appointments for post DKA follow-ups. So we added this every single week. On Thursdays, we have DKA follow-ups, and this is goes to our physician on call. And so they are seeing these patients. It's great, except the weeks that we have a lot of DKA admissions, and then they fill up very quickly, but it's a way that we figured out if they have a schedule up or a follow-up scheduled within like the next 8 weeks. Yes, that's not in like the 28 days, but we call that a win, especially if that's what their known provider. But this is how we figured out it is helped significantly. So our first PDSA cycle reduced the follow-ups from 63% to 52% after 6 weeks. And then our second PDSA cycle reduced from 52 to 35, and that was after the 12 weeks. So we're not following this. We're still not following this now, but we were over the 8 months showing persistent improvements within the 28 days, averaging about 41%. So we didn't quite make it to the 40%. We got down to 35. We are at 41. But adding those 2 clinic appointments helped. It helped. We went from 63% to 41 on average. So 80% of patients showed up for their follow-up appointments compared to 89 at baseline. So using this QI tool increased the access in guided workflow. So our nurses are now scheduling. So our CDEs, I'm one of the CDEs on the team. I didn't say that, but I am one of the nurses on the team, and that is our responsibility to make sure that it's scheduled. And it's also in our documentation, which was shown, here. It's shown in our documentation that when we go into chart on them through Cerner, it says when is their outpatient visit scheduled. And so then we have to put yes, it's scheduled, whether it's virtual or in person, and then when it's scheduled. So that is making us accountable for making sure it's completed and done when we do our charting. That is it. Do you want to take questions now, or do you want me to? Sure. Okay. Do you guys have any questions? Yes. Hi.
I'm just wondering if there's any correlation that you noticed between the time to follow up and whether or not they kept their follow-up appointments. Meaning, if they were going to come in 2 weeks, did more of them actually keep that appointment than the people who came in scheduled to come in 10?
The question was, how often are people showing up for their appointments if it's a closer appointment time, whether it's 2 weeks or if it's out 6 weeks, are they keeping it more often? I honestly don't know what the statistics are on that. I don't know. So sorry. Was it very helpful?
I was going to ask, who are the appointments scheduled with? Is it the CDE? Is it with the fellow? Is it with the provider? Or is it whoever can see them?
So the question was, who is the follow-up appointment scheduled with? It's scheduled with one of our providers. Yeah, and so it's either a nurse practitioner or our doctors or a fellow. And so wherever we can get them in. And so if there's an appointment that's not in the Thursday the 2 appointment slots for DKA, sometimes we have a fellows clinic on Friday, and sometimes they go into that just because there's more openings. We really do try to get them in with their provider if there's an opening, but some of our providers are out like 4 months, and so they can't be seen. Yeah. Mm-hmm. I think the question was like, how far in advance are you asking? Like, I think they're 6 months out. Ryan, do you know? Yeah.
Nothing else suggested. Like the scheduling center.
Any other questions? Yeah. Yes. Yeah, so our question is, the question is, do they stay with the provider they see at the DKA follow-up, or do they go back to their original provider? I mean, our patients have the choice of going wherever they want. Like if they don't feel like they fit with their provider, we like highly encourage them to go find someone else. We have, Mark, Ryan, how many providers do we have? 28? Okay, we have 28 providers. So we have a lot of providers and we go all over the city. And so it just depends. And some of our providers are booked out really far and some aren't booked out as far. It really just depends on how popular you are. No, I'm just kidding. But
people will tend to go back to their original.
But people will tend to go back to their original follow-up providers because that's where they are in the city. So because we are a multi-state, our address is technically in Missouri. But like I live in Kansas, a couple of us live in Kansas, a couple of us live in Missouri. It just kind of depends. So we are a split state, but we have 5 out within the city, 5 clinics within the city. So it's easier for them to go back to their original provider.
14.
There you go. Thank you, Mark. Yes.
So different than that, because you have so many different providers and so many different things.
Mm-hmm.
Are the patients being admitted to different hospitals, or is it all being done in one central location, which is why you can do this?
Yes. So the question was, because we have so many locations, are they being admitted to 2 different hospitals? No. So, or more than that. So no, we have it's called the Adele Hall. That one is down in Missouri. And so there was a Kansas location pre-COVID. That one shut down like inpatient. And so there was never diabetes there though. And so the diabetes patients always went downtown.
Sometimes remote people living 3 hours away to the regional hospital, but then they may or may not get transferred to us.
Okay.
So it just sort of depends, but that's probably a tiny fraction, 3%.
Yeah.
Yes.
Couple questions. So you have a DKA follow-up visit type so that you're tracking the patient?
Yes.
And then second of all, when you open up those 2 additional slots per week, were those already an existing template? Or you actually had to create it? And so did you have to beg a provider to be?
So, yeah. The question was, did we have to open up new slots for these DKA appointments? Yes. So we made a new template. It's the on-call provider. So our providers are on for, correct me if I'm wrong, either of you, but like a week at a time. And so they just, it can be real busy for them. And so I don't think they loved it, but it was like what we needed to do. So, but you guys can correct me if I'm wrong.
This is the doctor, clinic on call doctor.
So there's an inpatient, doctor, and then there is an outpatient doctor on call. Yes, ma'am.
I have a question.
Oh, sorry.
But, have a structure by which you do your DKA follows up, or is it just kind of regular clinic? Or are there certain points that you hit, right? Or do you have a plan that was developed inpatient and then you make sure to follow up in those 2 weeks, or is it just like a regular clinic visit?
The question was, is this a regular visit when they come for the DKA follow-up, or is there a protocol that we follow? We don't have necessarily a protocol that we follow, but we do pay attention to like, what was the problem when they came in? Like, was it a pump issue? Was it them not taking their basal insulin, like what happened, or was it them not like rotating? So we do focus on that, but there's no specific protocol that we follow. Last question.
Is it always in person, or do you allow telehealth for your patients to live like 3 hours away after they've already mentioned that they are in the hospital?
Yeah. So the question was, are these appointments in person or are they virtual? We really like these specific appointments to be in person, but we are willing to do telehealth if needed, for sure, because we understand, once they're admitted, that's a lot of time out of their day, out of their work week, and all of that, just detouring from their normal life. So we're very flexible when it comes to that stuff. Thank you, guys.
Obviously generated a lot of interest. So let's go on to the next one. A program to decrease diabetes ketoacidosis admissions, diabetes wellness program, pediatric, presented by Roberto Izquierdo. Okay.
Thank you. I'm just gonna take off my jacket. So I'm gonna walk in here. What was that?
Yeah, you'll have right here on the screen.
Oh, I understand.
Yeah, great.
Okay, so, good morning, everybody. So I just want to tell you about our program to decrease diabetic ketoacidosis, the diabetes wellness program. And this was a team effort. We have a wonderful group, and some of them are in person here today. Emily Hess and Beth Wells and Dr. David Hansen. So, so the rate of decay is rising. In this report from Dr. Everett, published last year in the Journal of Clinical Endocrinology, the pediatric DKA admission had risen by 40% in the US, and the most vulnerable subgroups remain at higher risk. And the hospital, this report also showed that the hospital charges per admission increased from about 14,000 to 21,000. And this is despite a decrease in length of stay. Now, let me just show you. So in this group, they identified the vulnerable subgroups. I think I get here. So they include Black Americans, those with the lowest income, those families that have public insurance or no insurance at all. Also, those that were between 18 and 20 and between 12 and 14 years of age. Females were at higher risk, and also those that live in non-urban areas. So these studies plus others, and some from here from the collaborative, underscore the crucial need to study and overcome the barriers that lead to inequities in the care and outcome of people with type 1 diabetes to decrease DKA admissions. So we did a NISA assessment in sunny upstate Syracuse, SUNY, the University of New York, for the wellness program. So we identified 19 patients that had at least 2 or more DKA admissions between August 1st, 2019 and August 2020, and 17 patients who had at least 2 or more DKA admissions from August 2020 to August 2021. Patients identified were also those with frequent ER visits, sustained A1Cs greater than 14%, or who had frequent outpatient calls. So we created 2 intervention groups, cohorts, 16 patients each. So our thought was to decrease the DKA rate. We needed to address diabetes care and education, as well as the SDH. So here, let me just make this. So, and we enroll patients aged 18 to 21 with multiple DKA admissions, or those with 1 DKA admission who had chronically elevated A1C per provider discretion. So they have monthly visits with an NP for 6 months, as well as a diabetes care and education specialist and a registered dietitian. And we have social work consultation as needed. Now, some patients were returned to usual care if they had 3 no-shows with the NP or DCES or unable to contact the follow-up group. Sure. So our group created this curriculum. So in visit 1, we set up my chart, which we have Epic, and keeping a log, setting SMART goals, and nutrition needs assessment. And this was actually moved to the visit 2 because of lack of time. Then we review ketones, assessment, sick day management. And visit 3, we review hypoglycemic protocol, review of glucagon administration, review New York driving laws, if applicable, the importance of checking blood sugars. Group 4, visit 4 and 5 were dedicated to sports and exercise management, technology, increasing independence, identifying blood sugar patterns, making changes on those patterns, establishing routines. And then the final visit, we review independent dosing changes, patient could choose their topic, and trying to keep those habits we mentioned before for maintenance. And then an after-hour games where they review like different clinical scenarios. So this is our cohort. 18 patients completed all 6 visits. The mean age was 15, 44% female. 2/3 were white, 28% were Black, and 5.6% were mixed race. And most of them, as you can see, had a very high rate of public insurance. And this is in comparison to those who are returned to usual care with 14 patients. Then we compare it to a control group, age matched by age and diagnosis, and the 81 shown here. And those, most of these had insurance, so they had less DKA episodes. So so some patients benefited greatly from the program, as shown here. This is patient 8. The patient has 7 admissions prior to the intervention, and then after the intervention went down to 1. And then the patient 12 also had 9 admissions, and then as last follow-up, she was 0. And then I'm just picking some samples. And this patient from cohort 2, patient 1, that his or her A1C dropped from 11.9 to down to 8.2, and then this other patient 13. The A1C dropped from 13.2 down to 8.5. So this is our clinical outcomes in the completed group. The A1C decreased from 12.7 to 11.3, and DKA emissions decreased from a mean of 3.28 down to 0.8. It's interesting, DKA emissions also dropped in the other 2 groups. But you can see also with the intervention, those patients have more CGM use, 78% as compared to 58% in the control group. So, so the completed group was compared to the control group not enrolled, and the mean decrease in A1C was 1.49% versus minus 1.4% in that non-enrolled group, and the mean decrease in DKA emissions was drop of 2.39 versus drop of 0.9. This is compared to that. We also had the patients complete the T1 and quality of life measures, and 77% of the participants who completed the program had an improvement in quality of life score, as shown here, when you compare the pre and post. And then in a post participation survey, all patients thought that the program helped them prevent DKAs. They thought that it improves their quality of life overall, and they feel more confident in managing their diabetes. So what we learned is, the program is effective for those who attended and completed the program. So 44% of the patients did not complete follow-up for various reasons. So we want to increase that rate. So we want to make the program more accessible. We think that we could cover all the topics in less visits. So the next steps, we're going to transition from the DWP to the DREAMS pathway. which is diabetes resource, education, and management support. So our aims is to improve retention, improve patients' glycemic control, improve quality of life by addressing the SDH. So we're going to address those issues more energetically, the SDH. So the test of change, we want to identify and address the SDH now that we have social work support. It's more robust than before. We possibly may have a psychologist. So we want to try to increase the flexibility in appointment times. We want to increase accessibility by encouraging telemedicine visits, which we did offer, but in the other two cohorts. Also try to partner with school nurses if possible to improve televisits at school. And for some families, also increase the involvement of case management and social work services. I think case management is so important in some of these families that need support. And also increase the use of technology. So we want to increase the hybrid closed loops. And then we have a child life. So we're going to incorporate her into our scheme. And hopefully she will help with that. And then hopefully have some, we're going to make it rolling admission. So if somebody stops coming, we can enroll somebody else. Thank you.
Got a few minutes for questions.
Hello. For this with individual appointments. Yeah. Well, now that you mention it, possibly might be a good idea. We'll put it in as a test. Yes, it may be. Actually, we did. We thought about it initially for this roundabout, but for some reason we decided. Well, we thought about it for the first visit, and then I think we would. Yeah, what was that? It's tricky during COVID, and so we'll see. I think the DCES thought that having some individual appointments, and we're going to incorporate the social worker right up front too. So to see why those patients did not come. You know, sometimes we do have gas cards and stuff like that we could give them. Yeah. Yes, like. Yeah.
Also completed a title initially if they enter the program.
Yes.
Go to them and get them to the
Yeah, that's a good idea.
I'm curious. Like, so
Yeah.
And what do you think that they did get out of the program that?
You know, well, I think some of them did participate several visits. Yeah, like 3 or 4, but that. Yeah, no, I think that's a great idea. We could do that. And then some of them that we couldn't get them. One of my favorite patients, we couldn't get her to come. So, and for, you know, and again, there were the SDOH that interfere. So we're going to try to address that more. Stronger. Okay, well,
So one of the things is, so inherently, the ones who chose to stay in the program were more motivated from the beginning, presumably, right?
Presumably, yes. Some of them, you know, there was various, I think, motivation, family. And also some of them, I think we saw some of the biggest changes in the ones with closed loop that got a pump and a sensor. I mean, that really helped them significantly. So we're really going to push for that. But I think some of these patients, they do need a lot of help. I had one patient that I gave her a pump and a sensor a year, and then she came back a year later and brought the unopened box. So it's like this a while back. So I think that's why I think case management comes in. I think we gotta, like, as opposed to another patient who had a very good case management, and she was calling us, you know, he needs more freestyle Libre. So I think. Oh yes.
I think.
Yeah. Hi.
How many outpatient follow-ups?
Oh, we haven't looked at that, but
Because
that's,
I wonder, you're basically delivering the care that they would be getting in their outpatient follow-up in phone calls.
Yeah.
Right? So you're basically meeting them where they are
Mhm,
and
yeah.
giving the care you would be getting.
Yeah.
So it's just another way to frame that.
Yeah. Yeah, we could look at that.
Yeah.
Thank you,
Oh,
Roberto.
thank you, thank you, thank you.
Okay, our next presentation is by Britaney Spartz, and it's on the utilization of CGM-based dashboard to identify at-risk patients with type 1 diabetes.
Hello, good morning. My name is Britaney Spartz, and I split my time between quality improvement and research at Children's Mercy in Kansas City. And just for context, I know you heard a little bit with Andie, but our main hospital is located in Kansas City with on the Missouri side. We also have a hospital on the Kansas side with several outreach clinics, and we serve about 2,400 patients with diabetes each year. And I'm going to talk to you about how we utilize the CGM-based dashboard for at-risk patients. I have no disclosures. So the TIE dashboard was originally created by researchers at Stanford University. It stands for Timely Intervention for Diabetes Excellence. It is a CGM-based dashboard that flags patients into specific risk categories and lets us see at a population level who we need to reach out to. The intention of the dashboard is to just see those patients and prioritize them, and then decrease the time spent reviewing patients on a regular basis. Here are two visuals of Stanford and Children's Mercy's dashboards. Stanford's is here on top and Children's Mercy's is on the bottom. Visually, they look very different, but essentially the process of using them is essentially the same. Each patient has their own row that is dedicated to them and lists just kind of some individual details about them. But Stanford uses more of a color coding system to just kind of address your attention to the certain areas such as time and range and percent time below.
We'll ignore that.
Screen.
Sorry.
No,
There we go. Okay.
thank you. Children's Mercy's dashboard is essentially the same, but we stick our risk categories right in the row where the patient is. And then Children's Mercy also has a function to search by MRN so that we can look up specific patients and see some history, such as weekly or monthly time and range as well. Implementation of these dashboards has been utilized in Python, Tableau, and Power BI, which is what Children's Mercy is using. So we know that technology barriers are really limited, and it can be adapted and used amongst multiple software platforms. These are our current risk categories that we're using. Most of these stemmed from the original publication from Stanford, but our team kind of collaborated and agreed that they were all the right risk biomarkers. And we also added that 15% drop in wear time. Here are some of the filters that we're using. These have been ever changing since the beginning as we just learn more about the dashboard and different cohorts of patients that we want to target. So far, these are the ones that we've added, and they've allowed us to reach out to patients that are new onset, new to CGM use, high risk, and lost to follow-up. Like I said, we started with just a few filters, but we just keep changing them, adding them. So we'll continue to do that as we decide on new patients that we would like to target. So what makes this dashboard so valuable? This dashboard is the first visualization tool that our clinic has had to prioritize patients at a population level. So we can prioritize who needs extra support, allow for more upstream intervention. And while the data is slightly reactive, it still allows us to address issues right now instead of 3 months down the road at their next standard of care visit. Okay, so far we ran a few PDSA cycles. Our first 2 PDSA cycles were led by our diabetes educators, where they reached out to patients in specific risk categories, and they provided some problem-solving support and insulin adjustments at that very first point of contact on the phone. Some barriers that we ran into in the beginning were patients populating in the dashboard that maybe didn't attend Children's Mercy anymore. Their data was out of date, or their time and range was greater than 80%, meaning not a ton of adjustments were needed. So we kind of refined our filters a little bit, and then our next couple cycles were led by our QI team. Our QI team reached out in the same way and targeted those same specific risk categories, but instead we tried to schedule them for a series of remote patient monitoring visits. We really didn't see the volume of patients that we thought we should. We kind of were seeing repeat patients from the first couple cycles. So this prompted a shift in our next couple cycles where we reached out to families and who were using Dexcom Clarity and tried to make sure they were streaming their data with our clinic. That also was not hugely successful because families answer the phone, they say, yes, I'm going to connect, and you invite them, and then they don't. So that is something that we are definitely still working on. So our results were really good in the beginning. When our diabetes educators reached out, we had more engagement and reachability, and then there's a sharp decline. And one of the barriers we think we have here is our clinic team reaches out to families from a clinic phone that has Children's Mercy as a caller ID, whereas our QI team is using Microsoft Teams, and caller ID is not an option at this time. So this is something that we're trying to address across all of our outreach to families because we notice it across the board. We've learned a lot in just our first few cycles of using the TIE dashboard. We know that this could be extremely helpful to prioritize patients at a population level and figure out who needs the most help. But we also know that families are really hard to outreach. And then even when you do, sometimes they don't think they need the help that their data is showing that they do. So that is, we are working on that. And then what's to come? We are conducting some semi-structured qualitative interviews with our clinic staff to guide our future PDSA cycles. We're asking questions like what they like, what they don't like about the dashboard, what they want it to do, and how they envision it being used clinic-wide. And then we're still fine-tuning some of those filters that are available within the dashboard. We're looking at adding a provider filter so providers can populate their own patients that they see on a regular basis. And then eventually adding an AGP to the dashboard as well. I just want to thank the Helmsley Charitable Trust for making our project and this team available to us. A huge thank you to our data science team for building the dashboard and answering all of our questions and all of our requests that we have on a daily basis. And then, of course, a huge thank you to our diabetes team and our patients and families. So, thank you. Yes.
Since some of the families are on this phone call, have you tried to do things with electronic messaging, such as with my chart, to try to connect with families, because that, you know, people should want to contact.
Yes. Yeah. So the question is if we reached out in other ways besides phone calls. Our clinic staff did send portal messages to try and get some feedback. We didn't have a ton of success in that. Our QI team in those first couple cycles did not send portal requests, but when we did do the outreach to get people connected through Clarity, we did call and we sent an email to go ahead and just invite them because that doesn't require a conversation. We just invited them to share with our clinic and still didn't get a ton of feedback on that.
Did you message to families when you were starting the program about the fact that they were and were families automatically enrolled in the program? They were sharing their data, or did they choose to be enrolled, and like did they know they might be contacted about their PGA?
So they agree to share their data with the clinic, which just kind of like populates them all within here. And then when we did outreach them, we told them that they fell in one of these risk categories. So they were aware that they were in one of those problem areas. Sorry, and I didn't repeat the question.
Like, how did you go about, because we have families, we ask them to share their share code, not invite them in, but we had to specifically tell our families we're not watching your data because we don't want them to assume that we're seeing, like if they're having lows or they're, you know, if they're kind of range and within range. How did you go about that in explaining that you fall into this risk category? And did you have any barriers thinking that you were constantly watching their rate, or did you not have any barriers?
Yeah, the question is just asking if we have any barriers with families being aware of their data being shared and looked at all the time. I personally have not come across that. We haven't had any families be concerned that we have access to their data. I don't know if any of the clinic staff in here have feedback.
There's been like a really high acceptance rate for what we're doing when we reach families. But I think we're still trying to figure out the secret sauce for how you outreach to them and get them to respond. And I I think that probably some combination of text messaging and portal messaging will be the answer. We're not there yet, but honestly, because we're constantly talking about the innovative things we're trying to do in clinic to restructure our clinical care. Our families in the diabetes center are very aware that we're constantly trying new things. So,
Go ahead.
That's one more thing, so from a patient engagement perspective, on deck, I'm sorry, you can have them all sign up and come for the weekly summary, and then they'd also be getting their message every week about their time to read it, and maybe that might help into patient engagement to go like, oh, I put this, point, even, or answering.
Yeah. Yeah. That's a really great point. Thank you. Yes.
Two questions, so thank you for this. I was wondering what, have you thought about Doximity texting? Doximity dialer has a texting service. And you can put a caller ID, so you can change the caller ID to be text.
Yes, so the question is if we thought about using Doximity as a resource, and we did have Doximity at one point at the beginning of the pandemic. I don't really know the whole reason why we switched, but I think that it can be costly, and we've got a pretty big team and do a lot of outreach calls. So
we still have a policy that prohibits text messaging.
Even for Doximity, like HIPAA. Oh my God.
So we have to update our policies.
Okay.
yeah, that's another issue.
I know you're going to talk to your providers about what they envision they're going to use it for. But I'm sure you guys have kind of thought about how often the provider is going to have to interact with the platform to then talk to the patient, and you probably have also thought about liability issues. So I would just love to hear the thought on that.
Yeah, so the question is about adding our provider filter and how timely that can be for them. And that is a work in progress. So we're going to continue talking with them and figure out how that all can flow together seamlessly.
We have a virtual question.
Okay.
You can, are you texting me? You
I'll
want to yell it? Don't yell it, yeah.
Does the CGM data get entered in the dashboard? Does it get automatically uploaded from Clarity?
So the question is how this data gets into this dashboard. So I forgot to mention that this is streamed through Clarity, T-Connect, and Gluco, and we have amazing data scientists that have an API connection, and it flows in, and they do all the legwork of it, but I think it's becoming more of a seamless process.
Is it an API connection from Clarity, or will that CSV put it into
The answer is both. So right now, it's export CSV, which you can do in Clarity by batch. You get the whole population every time you do it, but we're like hours away from signing our contract, and we have an API connection built. So we'll turn it on as soon as the contract is signed.
Okay, we have to move on to the next one.
Yes,
Thank you.
thank you.
So our last presenter is Jeniece Ilkowitz, talking on the implementation of a wellness program for people with diabetes with hemoglobin A1C greater than 9%.
Hi, so I am an RN CBE, but I also do research and QI work at the Hassenfeld Children's Hospital at NYU. These are just a few of the members that really worked on the wellness program in the beginning, but it's an effort from our whole diabetes team and front staff, everyone is part of it. So we did kind of borrow the name from SUNY Upstate after I heard a presentation a few years ago, so it's very nice. And so although I like that dream one too, so. All right, so with QI and learning from the type 1 exchange, I think it's always important to not only identify the problem, but then all the challenges that may arise once you are trying to solve the problem. So as we know that youth with elevated A1C are at higher risk for complications, and yet we didn't really have a streamlined program. We obviously were helping them, doing everything we could to support them, but we didn't have a process in place. So that's many of these fishbone things on here, but also we were aware that these are the patients, the ones with the higher A1Cs that may lack motivation to come to clinic or the ability to come to clinic or have other challenges, and that we didn't have a screening tool to identify those barriers. And again, that we just didn't have a plan for loss to follow-ups, identifying them, and then following them once we did identify them. So we also, as we were thinking about this and talking about it, we wanted to look at the data, and we knew there'd be disparities. And so we asked our statistician to kind of look at our baseline data, looking at our patients with A1Cs over 9% and comparing them to those with lower A1Cs. And our aim was to decrease the A1Cs of those with 9% and higher for over 20% of the participants within 6 months. So the next slide has all the information, but I'm just going to point out a few of the disparities that we noticed. So we looked at our population from August 2020 to 2021, and not very surprised, a significantly greater proportion of people who used CGM had A1Cs that were less than 9% versus those who did not. Same thing for pumps. And we did also see that a significantly greater proportion of minority race language group had an A1C over 9% compared to those that did not identify as a non-minority, or that identified as a non-minority race or language group. And then we did see a significantly lower proportion of minority group that used CGM compared to the non-minority group. And yet only 61% of the risk ratio for minority status could be attributed to that lack of technology. So there was still more going on. So we still need to look into that. And again, this is just the numbers. So we initiated our wellness program in September of 2021. So we identified all the patients with A1Cs over 9%, and we paired them with a CDCES. We wanted someone to focus on that person, and hopefully that would be the one that saw them in clinic and contacted them. So the first step was to call them if they didn't have an appointment, to schedule one. And for those that did, we just wanted to confirm that they were coming. And we also did confirm that appointment 2 days before, the day before as well. The plan was that they would have weekly contact with the CBE. And at first we thought they could Zoom in or have a call. And you'll see in our PDSA cycles, we realized that we needed a wellness phone that they could text, that we could put that number in their phone, and that would be best for this group of people. And then we did want them to attend a 6-week follow-up in person, hopefully, but we were also very flexible with that. And then we used shared decision making to individualize what an intervention we were giving them. So whether that was a check-in plan, whether it was supporting them in their technology use, getting them on those hybrid closed loops, or providing them with behavioral health and psychosocial supports. We also did create some more diabetes education and handouts and reinforcement, like DME supplies was a big issue we saw with a lot of patients, so we created handouts for them. The other thing, which was one of our PDSA cycles, was that we needed to screen for barriers. So with our integrated behavioral health team, we identified a tool called the PRISM tool, and it's a problem recognition and illness self-management tool. And it really looks at the barriers for adolescents and the parents of 8 to 17-year-olds, the unique barriers that they may have. So you'll see the 6 categories here: understanding and organizing care, looking at the pain and bother of diabetes, denial and of the disease and its consequences, healthcare team interactions, family and peer interactions. And on this tool, it's really easy. If they score over 2.5, it's positive for that barrier. So you don't have to read this. It's just calling out a few of the PDSA cycles. Basically, every patient we enrolled was their own PDSA cycle. The first person, she told us straight out, I'm not going to do this. I'm not going to come. It's fine. And that's when we were like, we need the phone. We need to be able to at least text her, just say hi, and we support her. And then we realized the second one, we had a team meeting, and we weren't sure if we were supposed to be telling them they were in this wellness program. So then we made a smart phrase and we made a great handout that just shows what does it mean to have an over 9 A1C? Like maybe these patients didn't actually know. So we have that on all of our tables in our rooms that now all patients probably see. And then really that plan for follow-up appointments has been a PDSA many cycles. We wanted the front desk to at check-in to make those appointments. That wasn't working so well. We have the CDCES walk out with them to schedule it at the end of the appointment. That's not always working. We think Epic should have something. So if anyone knows like how to track if it's been 180 days, like to send everyone a message. So we just need to keep doing PDSA cycles to figure this out. So those are kind of a few to call out. And then ahead of this, I wanted to look at the PRISM findings. You know, we did them on all these patients and wanted to see what was actually happening overall. So the adolescents that took it, there were 28. And we did find family interaction was one of the highest barriers, but they kind of like said all things weren't a barrier, but were a barrier. And then our parents of the younger guys, the 8 to 12-year-olds, denial seems to be the only actual barrier that was identified for them, but healthcare team interactions was low, so that was nice to see. And then our parents of the youth, you know, family interactions. I know we've seen that family conflict is a problem for families and diabetes management, so we saw that too. So the results of our wellness program, we looked at 464 patients and 82 were eligible for this program as they had A1Cs over 9%. And the A1C of the mean A1C of our wellness program was 10.6. And I was supposed to fill in total population, which was 7.5. The median age of both groups was 14. And again, we saw the disparities at 70.2% identified as non-white. So at 6 months, what did we see in that original group? We obviously had people come and go in the program, but we saw a decrease to below 9% in 32 of our youth after joining the wellness program, with a mean post-program A1C of 8.2. And the interventions were initiation of hybrid closed loop and really supporting them in that. Immediately it went below 9%. So that was a nice intervention we saw in 6 of our patients. That increased diabetes education and helping them with whatever supports they needed with their diabetes. We are so lucky at NYU. We have neuropsych, we have social work, we have psychiatry, we have psychology. They're not there every day, but we do have the ability to refer to them and they do come to our center at least a day a week. And so we were able to help 4 of our wellness program patients with behavioral health interventions. And then we thought maybe the increased communication helped with about 6 of them. And then we looked at 6, I looked at it with Vanessa, who manages the educators, and we know what it was. So we have to figure that out, but just being in the program maybe. So we have a lot to do. We want to do qualitative interviews to really understand what would help these patients. We added a social work touch point because we're doing this PRISM and maybe not doing enough with it once we see the results. So she'll check in at 6 weeks. Again, we need to work on loss to follow-up and scheduling at front desk. And then that PRISM tool is great for certain ages, but it doesn't capture everyone. So we need to figure out another tool for screening for barriers. And we have those chronically elevated A1C that we just need a reentry plan and what to do for them. They obviously need more support. So thank you. Yeah.
Great presentation. Our institution. I guess I have 2 questions. One for the phone. So was there, I mean, if you want to just go on the weekend or after hours, if there's kind of some understanding that I may not, you know, like for example, I can imagine someone texting being like, you know, like is there kind of an idea of conversion? And then my secondary question was, we did some health coaching and initially it seemed to really improve, but then, you know, they didn't do health coaching forever, it was like a few months, and then their A1C went back up. So is there anything you found that kind of kept, like, once they got to that goal, kind of kept them at that goal?
Yeah, so because, sorry, repeating the question. So with kind of rules for using the wellness phone for texting after hours and in general, I'll answer that question first. So they put on an automatic response for after hours, but they do educate. We have a wellness program phone. We obviously have an emergency line, and the people in the program, what the CDCES were doing was putting it in their phone, like emergency line save, wellness program save, so that we saw it in even putting their DME provider in, like we realized that how important it was for it to be in their phones. There's some patients who use it a lot, and then it's not getting used maybe as much as we even wanted to. So I don't think there's been any huge problems with it.
No,
So
I think it's so much about the individual and being who they are. Like you said, some people use it constantly and it really helps them. And some people never use it. So it wasn't really something that helped them at all. But for those who needed it, it's been a great deal.
yeah, and we actually just recently, one of our next PDSA cycles is we just are going to send tips. Even the people who say I don't want anything, we're sending them a 2-sentence tip on diabetes once a week for 6 weeks, because we still want to do a touch point. And you had a second question and I'm forgetting what it was. Oh, how do you sustain? So yeah, we are looking at that now. We are only a year into it. So we are deciding to re-enter chronically elevated after, like, giving them a break. Maybe something's going on. Maybe they just need to mature. Whatever it is, we want to give them like a 6-month break before re-entering them. So we'll have to see what that looks like and if it helps bring it back down and if it maintains the lower A1C again or not. So
We only have time for one question, so.
yeah, the question is, what did our information sheet look like for the patients entering the wellness program? So the information sheet, because we didn't want it to be too much, but we also needed to be honest. We did the colors, but made it more like rangy. We did time and range. A1C was kind of on the side. And we said what it meant in nice words, like, yes,
So even
very positive.
you have a left way to have these things as opposed to that might not sound important. That might look like we could do it together, like we can lower your risk of this and this and this. And
Yeah.
they was fun.
Yeah, it doesn't seem very aggressive as some of those look like danger zone. We didn't do a thermometer. We did it because that kind of looks it's scary. We did like just a box and it was all like just very simple. We can send it.
That data, the risk is
Yeah.
there. But the colors too, like you still did, like we read that, and but you like talk to us about green. Yeah.
Yes. Yes. Yeah. Yeah. We use that chart. So so they can look at the line that has been proven if it's lower. Yeah. Yeah, I'll send it your way.
Okay, thank you, Jeniece. Look on the way out, they're going to be directing you, there's going to be a group picture. So follow the indicators out there that will all be outside for a picture.